So very good
It's
morning.
not translucent, so if there is any remnant, so he has two birds in one stone. He cleans, and if there is any remnant, he can see it because it's not translucent.
So very good morning. And at the outset, I'd like to thank Dr. Rohit, Dr. Pooja, and the team NN for giving me this opportunity. So it's my journey from VISUMAX 500 to 800, and I would like to acknowledge Dr. Rupal Shah here for making me through this entire journey of SMILE. Is faster the better? Understanding the clinical outcomes in VISUMAX Pro. So we all as refractive surgeons know these essential steps which are a key for the CLEX or the keratorefractive lenticule extraction, which is a new norm or a nomenclature for all these lenticule extraction. So essential here is this lenticule base cut, the lenticule cut, the cap, and this cap side cut, which essentially takes 28 seconds. And what you see, the two images here, this is the VISUMAX 500, and this is already done a procedure on a VISUMAX 800, which takes almost 8 seconds compared to 28 seconds on the older or the VISUMAX 500 platform. So why does this occur is because the system is a 2 megahertz as compared to a 500 hertz system on VISUMAX 500. So the system becomes much faster. A lot of research by Google came out, the average attention span of an individual is close to around 10 to 11 seconds. So if you actually make the patient sit and concentrate for less than 10 seconds, you'll have less of suction loss. So this is what actually translates into close to zero suction losses. So 1800 eyes that we did, the suction loss was almost close to 2, and these were those kind of maybe what Dr. Rohit was talking about, some kind of, the fast movers or some kind of neurotic patients who actually went into anxiety spells and there was a suction loss. So, but believe me, from 500 to 800, the transition of 28 seconds, because world over the studies in the multi-center studies show that the suction loss is close to 1.34%, and the suction loss would occur in the first 14 seconds. So 52% times it occurred in the first 14 seconds. So this chart no longer stands in my OR, which used to be there as my prime concern when I was operating on the VISUMAX 500. So we have been talking, and Dr. Pradhan has always been talking on this podium of the variables that we can do on the various CLEX platforms. So watch very carefully. We can change the energy levels, the spot size, and the spacing. But actually, if you see the dissection here, what made the difference is the newer software changing the spot spacing from 4.5 to 3 microns for the lenticule cut, and for the side cut to almost 1.5 microns. So the tissue separation is very, very easy now on this platform. So I think the wow factor, which doesn't need to be supplemented with any of those, I believe the steroid supplementation, and the wow factor is there within 24 hours on day one on this platform. So this is the initial, the outcome that we have realized on the 1800 eyes that we did so far. And this is a wonderful paper published in Cornea by none other than Dr. Tetyal, Dr. Namrata et al., which came out that the learning curve of SMILE is surgically challenging. And the most critical here is the dissection, because most of the complications would occur when you are dissecting the lenticule. So you can have the cap cut, cap tear, you can have the side cut tears, partially retained lenticules, or the completely retained lenticules. But if you have with this energy levels, the dissection is so smooth that hardly any patient has any of these complications sitting there. I would like to acknowledge this slide, and this is from the Vision Eye Center. What you actually see is the pupillary center here. This is the centration, which is the centration target in 50% of the pre-op, the X and the Y coordinates. And this is what the Purkinje sensor image is. So this is the visual axis, which when you view from the coaxial light source. And this is the actual achieved centration. So this is what you call as the chord mu, and this is the level of decentration that is achieved. What we found in the system is this wonderful center-aligned technology, which actually takes care of the decentration. We all know that if the ablation is decentered for more than 0.3 millimeters, it actually translates into induction of more of aberrations and coma. And this is translated much higher or multifold when you are actually treating an astigmatism of more than 1.5 or 2.5, because then it's decentration and as well as the astigmatic component which actually matters. So what happens on this platform is the patient is first taken on an atlas where you have the XY coordinates, and this actually takes care of the angle kappa. So if you see here, this is how it actually works. So the patient is there, the docking, this is the central mire. You actually need to have this, blue means less than 0.1 decentered, yellow would mean less than 0.3, and this is here where the figures really pop up. So once you are centering before docking, you actually need to turn on the infrared cameras and then actually see where you are centered. So just watch carefully, and this is the infrared camera, so it's slightly decentered. I try to make it centered, and there, so even a slight drift, shifts, and this is close to 0.3 millimeter decentered. So the treatment is there, bang on, and this is all actually, the paper which describes this is the publication in Cornea, which actually says that the adjustment of angle kappa during SMILE resulted in less HOAs. So I think centration is a very important factor, and the initial studies that we had on the refractive and the visual outcomes in patients with myopia on the 800 platform, and if you actually see, the preoperative spherical equivalent came down from minus 4.23 to almost close to minus 0.12. And so that's the wow factor which these patients actually enjoy. So the proof is the fall in the HOAs, and I think what we believe it's the centration. So from preoperatively 0.31 boiling down to almost close to 0.16 with this platform. And if you see, the coma went down from 0.1 to almost 0.07. The third important feature here is the OcuAlign system, and recently we were updated with this OcuAlign. So initially, when we were doing, the patient had to be taken on a slit lamp. We were doing 2 axis marks, as we saw the last video. So what I do is I do 2 0-180 marks on the slit lamp, and then this patient is taken on the 800 platform. Watch very carefully. This is once you apply the suction, and then on the go, you can actually rotate the joystick to accurately compensate the cyclotorsion. If you see here, you can rotate, and then you can align on the 0-180 degrees. But what has been now a game changer is this. With the alignment of the ILMaster 700 and the forum. So this forum is the refractive workstation where all the 3 equipments speak between themselves. So the patient is taken on an ILMaster 700, the iris image is captured, and this iris image which has been captured is then taken on the refractive workstation. So data once fed onto this refractive workstation, and this is the iris image which is then taken up on the refractive workstation. So it's similar to what you do the toric IOL alignment, and but here the component is this automatically taken now from the refractive workstation to the VISUMAX 800, and watch carefully. So as we go here, we start the docking, and this is here, I apply the suction here, and once you apply the suction, the infrared camera starts on. Now it'll ask you to check the cyclotorsion. So sorry for that, a little glitch. Adjust and confirm the cyclotorsion. So where this, if you see the 2 Myers, let's take a minute. If you see the 2 Myers, there is a slight component of cyclotorsion. Watch very carefully here. There is a, see here, there is a slight error of cyclotorsion. Now you can rotate the joystick on the go. So, and now you check the image, iris image, and then display the live image. So you click this again, display the live image here, and the moment you click, then the process starts. So this is the live image, and then you can proceed with the lenticule dissection. So I think the toric alignment is absolutely well taken care on this 800 platform. So a combination of good center alignment with the OcuAlign for the toric works very well. And so this data, though, is not with this, the feature, but even if with the markings, we treated cylinders from minus 0.25 to minus 4.5, and the average cylinder was close to minus 0.65, and so this is the pre-op vis-a-vis the post-op minus 0.05, and the safety index was close to 1, the efficacy was close to 0.94. But yes, there could be enhancement rates after SMILE, but I think with people, Dr. Rupal Shah has her own data here, and so a lot of literature in the world which reports that the retreatment rates after LASIK is usually between 5 to 10%, but yes, the retreatment rates is very, very low with SMILE, and but we need to understand actually, because since this CLACS procedure is coming in vogue, I think this is the only platform which actually gives you what is called as the circle software. One is very interesting. You can have PRK, you can have the femtosecond LASIK, you can. What is interesting is the secondary SMILE, and a lot of people have talked about secondary SMILE, which is actually a sub-cap lenticule extraction. So once you have done this, you can in fact create a lenticule dissection, because this dissection is no longer required, and you can just do a cleavage on the lower part and then take away the residual refractive error. Quick word with the Circle software, which is a feature only available on the VISUMAX platform, and this actually helps you to convert the cap to a flap. So the patient dog, you have to have the parameters available in the system, and once those parameters are taken, and you can actually watch carefully, this is the rim which is created, and so this then can be dissected, and the cap which was there is now like a flap, and then the residual refractive error can be taken care by the excimer laser ablation. So very carefully, you dissect all 360 degrees, and then this can be gently be raised. So this is how the cap is then made a flap, and then the excimer is proceeded. So I think the take home on the 800 platform, what we found in 1800 eyes, it is excellent refractive results. The day one, the wow factor, the HOA, the cylindrical errors, and the cyclotorsions are quite predictable. Suction loss, hardly any case, so it's very, very safe. The patient is quite comfortable. The pain score and the vision quality is absolutely amazing. And the workflow is quite dynamic. You end up spending less time when you have the workflow on the patients. It takes less surgical and OPD man hours, and it gives you peaceful both for the doctor, the patient, and the staff. Thank you very much.
As he's getting ready, any questions for Dr. Sonu Goel so far?
Rohit, one
Yes,
small question. Sonu, fantastic presentation. Could you hear? Hi. So, in fact, the chance of suction loss in my hand, past 15 years, I never had a single suction loss, even with the VISUMAX 500. But the other advantage, in upcoming course, if you are doing a hyperopic treatment, that takes a long time with the VISUMAX 500. That really, I think VISUMAX 800 will have a big edge over any other this thing, because it takes a very less time, especially for hyperopic.
Yeah, I think that's a very nice point, because hyperopic SMILE would take more of time. But yes, since you've been training and in experienced hands, I think the suction loss is hardly to be seen. Acknowledge that.
Thank you.